Hello. Good afternoon. It is really my pleasure to push up the 12th edition of Bulgarian Bifurcation and Complex Intervention course, and we are starting with our program. Now it is a fellow dedicated sessions, and I'm sure it will be more than interesting and much beyond the interest of fellows and the expertise of fellows, because we have a faculty panel, and I'm glad here to present you. Of course, you know Dr. Ifuvar, who is going to moderate the session, Dr. Chico, Dr. Raviner, and of course our friends, well known, all of these people are well known, Dr. Guy Hendricks. And I propose to start with the first presentation, but I will give the floor to Yves, just to start with the program. Thank you for coming, and I hope that this event will be useful for all of us.
Good afternoon. So I will introduce the first speaker, who is Guy Hendricks, coming from Brussels. You know very well because he has been in this meeting many times, and he will speak about FFR concept, development and basic principles. Guy.
Good afternoon. I thank the organizers for still inviting me after all those years. And I was asked to talk a little bit about the FFR concept, the developments and some basic principles. So few equations have had the power to bend the course of the 20th century, like the E equal mass to velocity to quadrant. But we can also say that few equations have had the power to bend the course of the interventional cardiology, and the equation is the FFR equals PD over PA. I will briefly give you some historical perspective, two hydraulics formula which are important, a few bases of the coronary circulation, and then go to the FFR derived indices. Just to remind you that PCI was introduced for one vessel disease which caused ischemia. So this was a causal relation between the one vessel, the one stenosis, and the symptoms. So it was a lesion-specific approach, and a successful PCI with disappearance of the symptoms was proof of concept. To remind you, and those too young to remember this, we measured pressure in the very first beginning of the PCI era. The initial catheter didn't have a guide wire, but had a second lumen to measure pressure on the one hand, or eventually to be used for perfusion if needed. Balloons were still a 4 French shaft, and a post-PCI, a mean pressure gradient of less than 15 millimeters of mercury was an acceptable, good result. But this to remind you the first balloons we used to. I'm sure no one in the room would dare taking this device and open up an artery. Even Grunzig conceded that the resting gradient is far from enough, but unfortunately it's all I have for now. So after the slow start of PCI, we saw an unbridled growth of procedures, because PCI had become a very simple task with minimal complications thanks to the rapid technical improvement of the material, guide catheters, guide wires, balloons, simplification of the procedure, introduction of coronary stents later on. We will talk about that also. Systemic devices like rotablation for special cases, understanding the pathophysiology role of platelets and introduction of potent antiplatelet drugs. Thus, all these improvements made it a very simple procedure, and so we saw a rapid expansion in the field from one vessel to two vessels to three vessels to left main and other indications like bypass grafting. Now, we saw that this growth of indication started to dilute the initial concept of Grunzig, namely the relation between an individual lesion and the severity of ischemia. So this relation was blurred, because if you have 2-3 vessels and you have ischemia, how do you know which lesion is producing the ischemia? So the mantra at that time was stent it all. And in addition, the advent of the multi-slice CT as a screening tool increased the number of diagnostic procedures, which was usually followed by an ad hoc PCI. This was definitely a need for a lesion-specific functional test in order to dilate just the lesions which needed to be dilated. So 2 important formulas to understand the FFR concept is the Poiseuille law, who tells us that flow is proportional to pressure, to the pressure gradient, and inversely related to the resistance, which is the length or stenosis or viscosity or whatever. But in the presence of a constant resistance, we know that coronary flow relates directly to the coronary perfusion pressure. It's a linear relationship. The second important law to understand is the Bernoulli equation. And this tells us that when a lumen decreases in size, in order that flow kept constant, it stands to reason that flow needs to be accelerated at the site of stenosis. So there was a transfer from pressure energy to kinetic energy, and as soon as the vessel widens again, there was a restoration of the pressure energy, but not completely to the proximal pressure. And this gradient across a stenosis was definitely related also to the increase in flow. Now, 2 words about the coronary circulation, then we go to the index. Remember that the coronary circulation is a 2-compartment model with, on the one hand, the epicardial system, and it's amazing, this is only 5% of the total coronary circulation. And on the other hand, we have the microcirculation, which is more than 90% of the coronary circulation, and consists of resistance vessels, which are less than 550 micron. And of course, there is no gradient across the epicardial structures if they are normal. Remember that at the entrance of the microcirculation, there are potent smooth muscle cells which are constricted, and we play the role of a lock. They can unlock or lock the microcirculation depending on the need, and if you abolish this lock, you will see that the coronary flow can increase 6-fold. So in the presence of a stenosis on an epicardial vessels, as we have seen from the Bernoulli equation, there will be a pressure drop. But usually, and we know that, the coronary circulation is usually also diffusely diseased. So that means that besides the pressure drop due to the stenosis, there will be also a loss of pressure due to the diffuse disease, and this part of the pressure component will not be corrected by stenting the lesion. So another important concept to understand is the metabolic autoregulation, how this flow regulates itself in the presence of a diminished perfusion pressure. Again, here you have our two compartment systems with the epicardial system, with the epicardial resistance, and the myocardial resistance, which at rest is very important. So we know from the Poiseuille equation that flow depends on the driving pressure, and inversely to the resistance, which is comprised of two components, the epicardial resistance and the myocardial resistance. And on the chart on the bottom left, we'll see here the relation between coronary flow and the area stenosis, which stenosis here, which will increase in the presence of a stenosis. So, whenever a stenosis occurs, the epicardial resistance increases, and due to the autoregulation, the myocardial resistance will decrease, and flow will remain constant, and so on. If the stenosis increases, epicardial resistance increases more, and the myocardial resistance decreases, up to a point where the myocardial resistance is completely abolished. And at that time, the only resistance who plays a role is the epicardial resistance. And if this resistance increases further, we'll see the flow to decrease. So it's very important to realize that over a large range of area stenosis, the flow remains constant. And we have analyzed this in 26 patients with a proximal LED lesion and with a normal LV function, in which we measured myocardial perfusion by means of positron emission tomography. And it's very astonishing to realize that over a large range of distal coronary pressures, flow remains almost constant. So the metabolic autoregulation is a very potent mechanism in order to keep flow constant at the level of the myocardium. In other words, the myocardium doesn't care about pressure, but cares about flow. So this summarizes this situation in resting conditions: high microvascular resistance, a low pressure gradient. As soon as the stenosis increases, we'll see the pressure gradient increase and the microvascular resistance decrease, and for a long time coronary flow will remain constant up to a level of, let's say, 80% diameter stenosis. In the hyperemic conditions, we abolish our microvascular resistance, drops to zero. The only relations is left is flow, which starts to decrease as soon as a stenosis occurs in the epicardial vessels with an increase in the pressure gradient. So now we come to the FFR relationship. And just to remind you, the concept of FFR is in fact a relation between two flows, two maximum flows, because FFR, you have to see it in the light of maximal vasodilation. It's a relation between a maximal flow in the stenotic vessel divided by maximal flow in the same vessels without the presence of the stenosis. So that means that if there is no stenosis, pressure, proximal pressure and distal pressures will be the same, and the ratio will be 1. In the presence of a stenosis, you will have a distal pressure and a proximal pressure. So how do we come from the relation of flow to flows, to maximal flows in the stenotic vessel divided to maximal flow in a normal vessel? How do we come to this simple relation, distal pressure to proximal pressure? Well, we know from the Poisson relation, again, that flow is proportional to the driving pressure and inversely relates to the resistance. So the flow in our stenotic vessel it's not PA, it's the distal pressure which is the driving pressure for the microcirculation, so it's distal pressure minus venous pressure. And in our normal vessel, it is proximal pressure, arterial pressure, minus venous pressure, both divided by their resistance. In our first, it's the resistance here in the stenotic vessel, and here the resistance in the normal vessel. Now, remember, we are working in hyperemic responses, so we abolish our microvascular resistance. That means that in both conditions, the resistance will be the same. Will be minimal, but will be the same. So we can as well abolish this factor. In addition, the venous pressure is very low. It's only a few millimeters of mercury compared to the pressure in the arterial system. So if we disregard this PV, this venous pressure as well, we will not be far off the truth, and that means that we are left with the simple relation distal pressure to proximal pressure. So actually, this relation interrogates the epicardial system from our two-compartmental system. So we are not investigating the microvascular circulation. If we want to interrogate the microvascular circulation, we have to use another parameter. In this case, we can use coronary flow reserve using velocity meters or absolute flow meters to interrogate this parameter. This is just an example that Doppler flow velocity increases spectacularly with the addition of adenosine in a hyperemic situation. So coming back to our fractional flow reserve, remember in normal conditions our maximal arterial pressure will give rise to a maximal coronary flow. In the hyperemic condition, because microvascular resistance is minimal. So we abolish this microvascular resistance, and that is the maximal the relation between maximal pressure and maximal blood flow in percent, expressed in percent. In our stenotic vessel, we also abolish the microvascular resistance, but here our driving pressure is not longer 100, it diminished to 70. So if we plot our 70 pressure, you will see that we will reduce our maximal coronary flow by 30%. Only 70% will. So this is in fact the FFR measures the proportion of your maximal vasculatory reserve. And it's a powerful index. Here 4,000 stenoses were analyzed, both classically with diameter stenosis analysis here, with the cutoff point less than 50% stenosis, more than 50% stenosis is significant, and the FFR value, cutoff value 0.8, all what's above is normal, all what's below is significant. So what we see here is that 90% of the lesions have a normal FFR, but a significant diameter stenosis on angiogram. So this is false positive analysis. In addition, 40% of the lesions have an abnormal FFR value, but have less than 50% diameter stenosis on angiography. So that means that in total, 33% of those 4,000 lesions were misclassified by angiography. So a few issues, since we work under hyperemic conditions. Maximal coronary blood flow is mandatory, and there are a few issues with that, because we may not be able to reach maximal coronary blood flow due to microvascular disease, because our vasodilator stimulus is insufficient if we use contrast or adenosine or papaverine. There may be endothelial dysfunction and shear stress abnormalities that diminish the achievement of maximal coronary blood flow. There are neural-mediated vasomotions, myocardial compression, and also circulating catecholamines. Just a parenthesis here about the neural-mediated vasoconstriction. It's standard when you do a coronary angiogram to give heparin first and give an intracoronary nitrates to start before you make a first angiogram. No, I always tell my fellows, don't give nitrates for your first shot. Give a first shot à blanc, give heparin, and then do your first shot, and then you stay in the same incidence, and then you give nitrates, and you repeat that angiogram, and you will be astonished to see large variations in vasomotion as in this situation. So we close the parenthesis here again. So we measured the hyperemic pressure gradient in normal arteries. Normal arteries either were pristine, completely normal, or there were some wall irregularities. And in the very normal arteries, there is a very small gradient over the length, mean of 5 millimeters of mercury. In the arteries with some wall irregularities, but without any stenosis, we'll see that there is a large variation in pressure gradients, and even 8% of those have values that are higher than 25 milliliters of mercury, which is the cutoff for being significant. So diffuse disease can indeed have a profound effect on the resting gradients in the vessel. So to extend the FFR for a local stenosis towards the whole artery, one has devised the pullback pressure gradient index. So what we do a mechanical pullback over the whole artery and measure every millimeter a pressure gradient. And it's amazing, if you have a very focal disease, you will have indeed a discrete drop in pressure, and you have a very large PPG index. A large PPG index will mean a focal lesion. On the other extreme, if you have a very diffuse disease, you see that the index becomes very low. And indeed, if you look at the tracing, you don't find any peculiar step-up, meaning a significant local stenosis. And of course, you have situations in between where you have a sharp step-up of the pressure and a diffuse component as well. So this is an important index as well if you are faced with diffuse disease in general. So the FFR index provides an objective estimate of coronary lesion severity with a cutoff which was initially set to 0.75. At that point, the results were 94% sensitivity. So that means that a few of those patients, of those lesions, would have been not have been stented. So they moved up to make sure to the 0.8 value to distinguish between ischemia inducible versus ischemia non-inducible lesions. And as we know, this has been confirmed. The superiority of FFR-guided revascularization has been confirmed in prospective randomized trials as well as in non-randomized trials. Just a last word on the FFR-CT and beyond. We know that the last year technical improvements in CT scans have made it possible to really have nice data. And here, with the increased detector scans using dual source and iterative algorithms, we can really reconstruct the anatomy very well. If you then choose the right physiological model and computational fluid dynamics to calculate the FFR for the whole coronary tree, it's very impressive that you can improve the sensitivity of the classical CT angio. And here is a trial comparing CT with FRCT. I just want to point to the fact that the false positive can be reduced by 70% using FFRCT. Even a head-to-head comparison between non-invasive cardiac stress tests like PET, SPECT, CT, and FFRCT, if you look at the FFRCT curve and area under the curve, this is the better test compared to the classical stress test. This is an example how accurate the FFR-CT calculated from the CT scan compares to the real FFR-CT from a pullback. And this is also true pre and post PCI. The invasive FFR shows this gradient disappear, and also on the FFR-CT, if it's repeated after the PCI, it's our comparable curves we can be superimposed. And of course, you can even use these heart flow meter as a gamer, and you can start analyzing your anatomy and say, well, probably we should put a stent in here, and then you can evaluate what would be the result of putting a stent in that location, and you just you recalculate the FFR-CT, and you see here not a big difference. And in fact, this patient was later on dilated. You see the stent in the proximal LED. And if you look at the FFR pullback, 0.73, remember it was 0.67 on the FFR-CT calculation. So this is also very, very helpful. We can then end up with a kind of a SWOT analysis of the FFR index. The strength, of course, is based on a hydraulic model. The normal value is 1. It's supported by trials, and it's recommended in the guidelines. The weaknesses, it's an invasive procedure, it's costly, it has issues in multivessel disease, and of course, should be added here, the maximal vasodilation is important. Opportunities, of course, it's lesion specific. It has related indexes. We will hear more about that during this course. It also has now a non-invasive brother to help us, and it's becoming the gold standard in PCI procedures. The threats, well, we have competing technologies, there are trading barriers, there are costs included, and also endothelial dysfunction maybe play a role in not achieving maximal hyperemia and therefore not accurate gradients. I will leave it here. Thank you.
Thank you, Guy, and welcome again after some missing you for some years, but I'm really glad to see you back again to our podium. So, questions, comments?
Well, it's very simple to say that I'm not a specialist of FFR. In France, it's even no more reimbursed. It was reimbursed, now it's no more reimbursed. So we use less frequently than necessary. My question is about the CT scan FFR and the invasive FFR. Invasive FFR, you are injecting some nitrates, so you are vasodilating the vessel, but not in the CT scan. So how do you explain that we find results that are nearly, superimposed?
Well, that's the whole software behind the calculation.
Calculate this.
Yeah, it's fluid dynamics, and it's a complex procedure also. In order to get those calculations, it takes hours to have a real result of your image.
And the complement of this, do you think, will replace definitely invasive and soon? This is expensive. Is there still only one company using this?
Well, it's expensive. It's also time-consuming. So those are the drawbacks of the FFR-CT. But have you seen, the example is really almost identical if you calculate and if you have the real good flow dynamic software to analyze the FFR-CT.
What is missing in CT FFR is that in CT scan is that we are missing the true diameters of vessels. To prepare a strategy, for example, for a bifurcation, having the diameter is very important.
Yeah.
Maybe I think that Dr. Mileva, because she was involved in verification of the FFR-CT in OLV, by the way, 3 years ago, so maybe she can comment something.
Thank you. If I can add just to the question of Professor Louvard, when we analyze the P3 results, which are the one that Professor Hendricks showed, when we assess the agreement between FFR-CT and invasive FFR, we did sub-analysis based on the nitro dose that was given before the CT, the sublingual nitro. And we saw that actually the patient that received 0.8 milligrams of nitro had the best agreement, better than the ones that received 0.4 or 0.6 milligrams. So the higher dose of sublingual nitro, the better accuracy of the FFR-CT.
So they give nitrogen.
And so we may have the diameters all along the coronary tree in the near future, maybe. So prepare a complete strategy only on non-invasive imaging before going to the cath lab for PCI.
I think it's coming. Thank you.
Maybe to add that recently a second company has got approval in Europe, and they calculate the so-called CT QFR. And so it's the same approach as in QFR. You don't need hours to do this complex computational fluid dynamics analysis. It takes only a few seconds, similar to QFR. It's quite sensitive, but not so specific. But maybe it's also helpful for the analysis.
Yeah, I had a question of experts. What happens when the patient has a fast heart rate, irregular heart rate? Also, what happens in segments that are not clearly delineated, proximal segments that have overlap? How accurate is CT-FFR in those situations?
Maybe I can respond on it because we work together with NIA. And I can tell you that there is no delineation. Just there is some segments, whole segments of the arteries, which are non-analyzable if you don't have a stable heart frequency, regular heart frequency, and maybe the best is between 60 and 70. So there is a limitation still for the CT-FFR. So thank you so much. And did we have a connection with Professor Gill? Because unfortunately he was unable to come here this year. Okay. А ще имаме ли после връзка с него? Не. Okay.
Good afternoon, my friends. I'm really very sorry that I didn't attend personally this beautiful and very important meeting which is held in Sofia right now. I really missed you. However, sometimes in your life you have to choose, and till the end you don't know whether you choose properly. Anyway, I hope you succeeded, you enjoy this meeting. Today I would like to share my knowledge regarding hyperemic and non-hyperemic pressure ratio parameters which are used right now in our cath labs. I don't have any conflict of interest regarding this particular presentation, to be honest. Everybody knows right now that invasive transdigital pressure measurements are very important in contemporary cath lab, and we use pressure wires which are inserted in coronary vessels, and with special softwares are able to record the distal pressure to the lesion and proximal one from the end of the catheter. Here you can appreciate recordings, let's say the screen with recordings showing bit per bit changes after adenosine insertion, and also mean pressure. This is fractional flow reserve as a ratio. Distal pressure to proximal one as aortic one. But of course, as all invasive procedures, there are some, let's say, complications, potential complications associated with this technique. But what is very, very important, that the quality of the measurements is a crucial thing. Without this very detailed pressure tracings, without keeping all of the demandings regarding good pressure measurement, our final results will be not valid, will be unreliable. Therefore, it's very important to look at since the beginning for the waveform of the pressure, potential distortion, let's say the presence of distortion of aortic away from this ventricularization, that is not also very good for the measurements. We have to be able to assess whether drift pressure drift is present, and of course in terms of flow. Fractional flow reserve, we need a maximal hyperemia. So therefore, we have to be ready to increase the dose of adenosine or the use intravenous infusion. In terms of hyperemic agents, I don't want to go into other potential products which are available on the market as regadenoson or papaverine still, but I would like to focus on adenosine, intracoronary and intravenous. You have appreciated here all of these details. There is no time to go into these details. I'm pretty sure you know all of the things. We have to remember that first of all, there is a real relationship between the dose of adenosine and effect of hyperemia. Here you can appreciate that there is a really strong relationship between these dose. But on the other hand, we have to remember that not all of the patients are able to tolerate so high doses. So the other option is just to use the one established intravenous infusion instead of this injection to bolus injection to coronaries. However, we have to know that the threshold, the cutoff criteria right now is 0.8, and of course we have still a kind of a gray zone just below a little bit and above up to even 0.83 zone, which should be treated as not 100% sure. And we know very well that based on these results, we can defer potential revascularization or to continue and optimize the procedures. Here, you just to remind you that very old, but very good trial defer, that was the first, especially for one vessel disease, showing that based on the FFR measurements in that time 0.75 was a cutoff criteria, still is for one vessel disease, by the way, gave us a very good outcome for these patients. If you see on the screen, you see the dramatically worse results in terms of MACEs for group, which was treated by PCI in that time. Of course, FAME 1 was the trial showing that we can rely on the FFR guidance regarding defer or decision-making process to revascularize or not. Here you can appreciate that showing that this is a superiority of FFR guided PCI compared to angio-guided PCI. We also know quite well that we can use this fractional flow reserve, say, parameter for bifurcations as well. Based on these results, we can decide whether we should or not to continue treatment of bifurcation, not only the main vessel but also the side branch. This is very important slide showing us that the formula which we use in our contemporary cath lab is very simplified. It's simplified only to the ratio distal to proximal pressure. But we have to realize that we have a microcirculatory system, we have a backflow from right heart, and we can also have some collaterals. These additional, let's say, components can influence, impacts the results. But for this particular system, for this, as far as we know, it was taken that the pressure, that the venous pressure is minimal, so the influence is minimal. The collaterals, which is not visible on the angiogram, is also should be negligible, and of course microcirculatory system after adenosine infusion or injection. This is the moment is minimized and stable. So taking all of these parameters, we can rely on these measurements. However, for any patients with problem in right heart or even with mitral valve, we have to take into consideration that the significant changes in venous pressure can really change the results of measurements. So we have to take it into consideration for sure. Here you can appreciate that in acceptable published papers, you can find that up to 10% of lesions should be reclassified due to the high pressure in right heart. Here you can also appreciate that in a presence of let's say significant good collateral flow, we can modify the results of traditional FFR measurements, just transregional measurements, and sometimes this is the reason that patient is asymptomatic or very low symptomatic because of this capacity of collaterals. We have also taken into consideration the area of vascular perfusion. We know quite well that sometimes, especially for, at least in my experience, especially with left circumflex artery, in the post-infarction area, even with the relatively high-grade stenosis, we don't see really negative, let's say, or low value for fractional flow reserve. So this is the reason, because there is a very strong relationship between the magnitude of area of perfusion and result of fractional flow reserve. We also know that we should consider the stenosis characteristics in terms of lesion length and some morphology and lesion, let's say, visualization. Eccentricity is just only one of the feature, because we have also different. So all of these, let's say, long without well-defined frontiers of the vessel, we can predict that the pressure drop will be higher compared to other situations. Then another phenomenon which should be taken into consideration, this is very important to know about it, this is crosstalk phenomenon for serial lesions, which when you start to look and to measure fractional flow reserve, it's a real problem, because we cannot predict the results without just correction of one lesion. So after correction one lesion, we have to go to the another one. The reason is that enormously increase the pressure before the second lesion. Let's say theoretically improves the fractional flow reserve for this lesion. So therefore, this is this necessity to reanalyze every single time after correction these sequential lesions. In terms of non-hyperemic indices, there are many today to be proposed by different companies. I would like to focus on 3: PD2PA, RFR, and IFR. Let's start with the simplest one, the most known, so-called resting distal to aortic coronary pressure index. Here you can appreciate a very good correlation with fractional flow reserve, acceptable negative predictive value and positive predictive value. The sensitivity and specificity is also at least acceptable. And then this 0.92 value is this cutoff criteria. However, we have a gray zone from 0.9 to 0.94. We have to be very cautious in this particular range. This accuracy is not ideal. So therefore, we need additional information using traditional, let's say, index, which is FFR. Here you can appreciate some results showing that singular assessment, singular parameter, it is PD2PA, is not ideal, but complex or composed parameter where not only cutoff criteria PD2PA but also for FFR is taken into consideration, and then this complex parameter based on these two is able to give us a real power in terms of base prediction. The second index is resting full cycle ratio. It's a kind of PD2PA, let's say, achieved by the filtering of the whole of the PD2PA across the cardiac cycle, and the lowest value is taken as this RFR. Here you can appreciate quite good correlation with a traditional FFR, with a good accuracy, sensitivity, and specificity for the value 0.89. This particular quite recent paper proved that this gray zone between 0.86 up to 89. This is the weakest point of this index. So therefore, we have to implement additional assessment using hyperemic index, which is FFR. So the next one, this is instantaneous wave-free ratio, which is a gradient across the stenosis during the wave-free period, when the resistance is constant and minimized in the cardiac cycle. So taking into account all of these non-hyperemic indices, using these methods, we try to reduce all of these bad impact of things already mentioned during the first part of this presentation. The measurements is completely the same. This is a ratio of the average PD2PA during the wave-free period. You can appreciate here that this is a part of diastole of cardiac cycle. It was proven by many small and big trials, this very high correlation with FFR, with very high sensitivity and accuracy. And what is also very important, that this cutoff criteria 0.89 was found as equivalent for FFR 0.80. And this particular consideration was tested in two very big trials, defined FLAIR and IFR Swedenhard, and it was proven that IFR is not inferior to FFR. However, we have to take into consideration that if we analyze the distribution of the lesion according to the achieved values, we see that these four quartiles, however, the more than 75% of persons, there is a very good concordance between IFR and FFR. Which is the reason of these differences? At least one, quite well known, the status of myocardium. Here you can appreciate that, and we have to remember that with fractional flow reserve, also with non-hyperemic indices, there is no, the assessment is only for epicardial arteries. There is no way to assess real microcirculation, which is able to be assessed by for example, for coronary flow velocity assessment. And then again, for quartiles showing that it's because of this weakness given by microcirculatory system, these FFR or non-hyperemic parameters can be not ideal. And then this discordance is very well shown here, that with the very good work of microcirculatory, where the hyperemia provokes a good coronary flow reserve, this FFR and IFR, let's say, fits one to another, with the situation of let's say, not optimal hyperemia, not good function of microcirculatory. This discordance is much more higher. And of course, we also know from the literature that there are some other, let's say, potential associations which shows us the differences between FFR and IFR, and also the rest of these non-hyperemic indices. This is a kind of grade of diameter stenosis, the reference lumen diameter, the location of the lesion, especially left main and proximal LAD, the age, the sex as well, diabetes, of course. And all of these things should be taken into consideration, trying to discover why we have this discordance or not. But just to summarize the problem of our potentials of non-hyperemic indices for functional assessment of coronary stenosis, we have to say that there is a kind of class effect. It doesn't matter which one we use, we should take the same cutoff criteria. However, this is true that IFR has the biggest number of trials. It was really tested in clinical scenarios. So therefore, it's up to you what kind of parameter you believe you use, but we have to look at the literature. It's very good that more and more companies start to assess, to use other non-hyperemic functional assessment parameters right now. Just one very important issue, which is assessment for serial lesions. It's much more correct with non-hyperemic lesions due to this pullback maneuver, which is very important in nowadays assessment of functionality of coronary stenosis. We have to discriminate the lesions as focal, diffuse, serial, or mixed. And to be honest, the easiest, the most proven, let's say, assessment is based on non-hyperemic parameters. So this is very, very important. Just for the end, a couple of remarks, which are also very important, because in nowadays this invasive assessment is very widely used, and sometimes we used to forget that the vessel distribution, especially plaque distribution, especially for left main, is very important. It impacts, let's say, the results of functional assessment. I don't have the time to go into the details. However, we have to be very precise and very wise analyzing the results, and in part of the say cases, the visualization, intravascular visualization, is necessary to understand the differences between the two branches of left main, LAD and circumflex artery. Why in one vessel is good value, the second is not one. So there's no time to discuss these issues. However, the plaque distribution influences the results. The other option, which is very important, especially for chronic total occlusions, we have to take into consideration one thing which is caused by the scar and decreasing the amount of myocardium area. And the second, this is a collateral which really influences the final result. So all of this scenario, for individual patients, should be taken into consideration. And remember, all of these parameters were tested for stable coronary artery disease. For acute coronary cases, we have to take into consideration the changes in the myocardium and impacts of these not well responding area to hyperemia, and changing the flow as results for analysis. We shouldn't assess in culprit lesion all of these parameters. For non-culprit lesions, we have to take into consideration there is smaller or bigger, but always part of the influence. And if we have borderline cases, it's much better to delay the let's say decision-making process, or even repeat the procedures. In nowadays, more and more cases with aortic stenosis are also tested with the functional assessment systems. Believe me, FFR is not good for that. Non-hyperemic parameters a little bit better, but still impacted by all of these changes within the myocardium, and this reanalyzing after valve implantation or only for valvuloplasty intervention is well to be performed before the final decision, yes or not revascularization on me. At the end, just to realize you that post-PCI physiological assessment detects suboptimal functional improvement in a large proportion of cases with apparently optimal geographic results, and could have a prognostic relevance in terms of vessel-oriented adverse events. So, just to simplify this sentence, we should assess functionality of the vessel after PCI, not only focus pre-PCI, because let's say the optimization can be done also with the usage of these parameters. At the end, what is the difference between hyperemic and non-hyperemic parameters used for functional assessment? Here you can appreciate that in nowadays there are theoretically only no differences. However, more and more information gathered with the trials showing us that non-hyperemic are very easy to be assessed. It's true that for Letman it's also a possibility to assess also for side branch and also for post-PCI. It's a matter of discussion where and how it should be done, but my approach is very easy. Hyperemic agents costs not quite a significant amount of money. The second, not all of the patients are able to survive, to be in good condition after this injection. Please try to do that for right coronary artery, for example. Let's say intravenous infusion is not so easy not to suffer for majority of patients, and new softwares makes our life easy, and hyperemic parameters can be used as a potential validation or kind of confirmation of the results achieved by non-hyperemic, especially where the results are strange, very difficult to be understood looking at the clinical status of the patient and angiogram. So, thank you very much for your attention.
Okay, that was a little bit tense, but some comments, short, because we are out of time, regarding the non-hyperemic indexes. Just for the faculty, from the last year we have a reimbursement for FFR. And this is why all this session and the focus about everything which we discussed today.
In France, 2 years ago we had it, and now it has been removed.
Yeah.
So.
But the reimbursement is only for FFR, so you have to apply hyperemic agents. The non-hyperemic measurements are not reimbursed, just to be clear. And also for our fellows, because there are a lot of them now.
The same kind of government.
Yes, and probably one of the reasons, because I was the initiator and I applied the documents from the Society for the Health Fund, because I cannot forget the words of Guy Hendricks, who told me maybe 11 or 12 years ago that FFR is approximation of something, and the IFR, non-hyperemic indexes, are approximation of something. And the clinical results from the last year, by the way, also from the clinical results for the non-hyperemic indexes are not so good as what were at the beginning. So we'll go further, and I would like to ask Juan, Professor Chico, to give his talk about the FFR cavities.
Thank you very much for the invitation. It's a pleasure. So let's see. So, anybody in the room recognize the music? No one? Okay. So that's the leitmotif of the Rhine River in Wagner's tetralogy. So in Wagner's Ring, every time the Rhine River appears at some point, it happens a couple of times, this leitmotif, this music sounds. So it was a very good introduction for Koblenz, which is the city where I am working, which comes from the Latin word castrum ad confluentes, because it's at the confluence of the Mosel River into the Rhine River. So I say it's the most beautiful bifurcation in Germany, the most beautiful carina in Germany. Since we are in the Bulgarian Bifurcation Club, it's the perfect combination. Thank you very much for this invitation, which I am delighted to take. Let's see, how many interventional fellows are in the room? Because I prepared a very simple, practical presentation addressed for fellows. Okay, only one. There are more, but are a bit more shy. Okay, that's fine, because I prepare a very basic, practical introduction, refreshing the concept of FFR, how the correct acquisition of FFR is, going to the basics, and then a summary of potential caveats, common mistakes that we do when we are calculating the FFR. So, as Professor Hendricks has brilliantly exposed with a very deep theoretical background, the fractional flow reserve is basically the quotient between the flow, the maximal flow you actually have in your coronary artery due to the stenosis, divided by the maximal flow that you could have in your artery if the stenosis were not there. So, simplifying Poiseuille's equation, we neglect the venous pressure, and we simplify the resistance, which is probably the same, and then we come to the quotient distal pressure to the stenosis divided by the aortic pressure. If FFR has succeeded to be the most useful, most clinically useful parameter, it's because the stability. It's totally independent, or mostly independent, from hemodynamic factors. In this patient, if we have an aortic pressure of 60 or an aortic pressure of 120, we will measure exactly the same FFR. And this is something that does not occur with coronary flow reserve or with other physiologic parameters. That's why fractional flow reserve succeeded to become the gold standard for physiological assessment. Do we need hyperemia? Because now it's the moment of computational physiology that does not require hyperemia, of rest indexes that do not require hyperemia. So the question is, yes, for the FFR concept we need hyperemia. I will graphically explain why. So this is the coronary flow in rest conditions. You see that the bulls, the runners can easily go. I could close one of these doors, and both the runners and the bulls could easily go through the stenosis, so we would measure no pressure gradient. To see the pressure gradient, we need hyperemic flow. These are resting conditions. The runners go even walking and nothing happens, but this is what happens in hyperemic flow. Now you will see a moderate 50% stenosis appearing in the coronary artery because one of the doors closes accidentally, and then you start to see the pressure gradient graphically, to see the hyperemic, the pressure gradient. And this is something that you could only unveil under hyperemia, inducing a hyperemic flow conditions. You see that the gradient is even bigger, and even the bulls have to wait until the stenosis is resolved. no worries, because bulls are essentially peaceful, contrary to the belief, and they will wait patiently until the gradient is resolved. No carnage here. Well, now everybody's curious, but see how the bulls patiently wait until the problem is resolved. So, no problem. So, for the concept of FFR, we need hyperemia. Another key for the success of FFR is that it gives you a binary solution. You have to treat or not to treat. Because we usually say that atherosclerosis is a complex problem, but your decision is usually binary. We treat it or we do not treat it. So FFR accommodates to your decision, giving you a binary result. And as the speakers have presented before me, the discrepancy with the QCA assessment is already very well known. The gold standard, what we have to use is the physiology result. Although we need hyperemia for FFR, now we have rest indexes and we have computational physiology that do not require hyperemia. And sometimes we see discrepancies in the same lesion in the same patient. So, as Professor Vasiliev has explained, that it was not coordinated, all these rest indexes, all this computational physiology should be considered proxies for FFR, estimation of the FFR. So in case of discrepancy, FFR should prevail. And in case you cannot use FFR and you are not going to get the reimbursement because of the hyperemia or etc., no dramas. Because as Professor Gil has explained, most of the discrepancies happen around the cutoff value. And the benefit of PCI is maximal when you go far from the cutoff value. And the benefit of optimal medical therapy is maximal at 1. But this benefit of these therapeutical approaches goes decreasing around the cutoff value. Probably both of them are equally valid, and then you start to be more benefit with the other therapeutical options. So, if you implant here the stent, you are totally wrong, but you start to be less wrong, and at the cutoff value, both options are valid, and then from here on, you start to be better with the stent. So, if the discrepancy of your rest indexes without hyperemia and your FFR happens around here, there is no drama. Whichever decision you make, it will be right for your patient. So you can have both options and you will not be dramatically wrong. So no dramas. Take whatever is better for whatever reason you decide. So let's see now briefly how's the correct acquisition of the FFR in your cath lab. The first step is zeroing the curves. We have to give the system a reference value. For that, we need to flush the catheter with saline. Sometimes we have contrast, we have blood, which are going to interfere with a good curve. We flush the wire inside the sheath, and we leave the aortic point and the sheath approximately at the height of the heart, because it's the point where we are going to do the measurements. So, in practical, we see here an example. We see the aortic point to enter the catheter of the guiding catheter, and the wire, the pressure wire at the legs of the patient, where they are approximately at the heart. This is to give the system a rough approximation where the pressure is going to be measured. The fine-tuning of this normalization happens here at the equalization or normalization. At this point, these minimal differences of hydrostatic pressure will be normalized or equalized, and both curves become identical. So you have to, these are the three conditions you have to have. You have to flush the system. This is still not flushed yet. You see blood here. You have to remove the introducer, and you have to close the valve. These are the three easy steps that you have to do. The pressure sensor is at the transition between the radio-opaque and the radio-transparent parts of the wire. So you have to put this transition at the tip of the guiding catheter. And then you close the valve, you remove the introducer, and you equalize. And this is what you have to see. You have to see the same PD and PA values, and you have to see a PDPA, instantaneous PDPA of 1. Then you know that you are equalized or normalized, so, depending on the system. And then we start with the measurements. Keep in mind to remove the introducer, to close the valve, because sometimes to position the wire we give contrast or we reintroduce the introducer, and we have to keep in mind to remove it again and to flush with saline again. The first step is measuring the PDPA. There are papers with a threshold of 0.91 and some other papers, as Professor Gil has explained, of 0.92, but it gives you an approximation whether your lesion will be significant or not. Then we can measure the rest index, the IFR, RFR, DFR, whichever we are using. The thresholds have been recently explained. And if we have different lesions, we can do the pullback with the rest index if we want. At that point, sorry, we reposition the wire distally to the lesion at the same point that we have previously documented. At the same point where we have previously documented, and we induce hyperemia using adenosine, which is the most commonly used vasodilator, papaverine, nicorandil. There are different protocols described, but I guess adenosine is the most widely widespread. To register the FFR, it's important to register the position of the wire, because probably you can have differences depending on which position you are measuring. And keep in mind that FFR is defined as the quotient, the PDPA quotient, under maximal hyperemia at the steady state phase. You see, when the adenosine starts to arrive to the coronary artery and starts to have effect, the curves start to descend. But sometimes one curve goes down before the other one. And essentially, the system will register the lowest value. But the FFR is the lowest value at the steady state phase, when the curves start to go parallel again. And this is something which is commonly forgotten. And this is something that you cannot assess if you are using intracoronary adenosine. This is something that you can only see if you are having a continuous infusion, intravenous infusion. And some people end up at that point, but thing is not over. You have to pull back your wire up to the tip of the wire, after the tip of the guiding catheter, sorry, to check that you have no drift, that you remain equalized. Because sometimes you have done a lot of things, you have gone through contrast, you have damaged the wire, you have measured with the valve slightly open, a lot of things can happen, and you lose your equalization. So what you have measured is not valid. This is the so-called drift. We will go later on. So this is a drift. The PD and the PA are different. So you have lost the equalization. And the PDPA is 1.04. So it's not 0.0 anymore. So you have to measure again. Your measurements are wrong. Or correcting it, as we will see later on. This is what we should have. The same PDPA and the same pressure at the PD and at the PA in a ratio of 1. This was taken faster than the system calculated, the PDPA. Okay, let's see now, after having refreshed how is the correct acquisition of the FFR, let's see which are the most common errors we do when we try to do it. There are some errors due to the misleading reference value, some errors related to the acquisition, and some errors due to wrong interpretation of a correctly acquired trace. Let's see, because they are now, after seeing the correct process, they are very easy to understand. The first one is a misleading calibration, setting a wrong reference 0 in one of the curves. The most common reason for that is not having your catheter filled with saline. In most of cases, it's not very important, because the equalization or the normalization is going to correct for that. The errors due to the misleading equalization are more common, and they can have different reasons. The most common one is that you or forgot your introducer inside the valve, so it's not properly closed, or you have contrast in the guiding catheter when you equalize, or another important one is wedging. So your catheter in a very proximal lesion is occluding the vessel, and then you are normalizing in a different condition. So your guiding catheter is not measuring the aortic pressure, but it's measuring the distal pressure of the aorta because it's wedging the flowing of the coronary artery. We will see it in more detail recently. A very common mistake is the presence of drift. It is very often not even analyzed, not even checked in the FFR acquisition. And the drift is having a pressure difference at the tip of the guiding catheter after the pullback we perform once we have done the measurement. Here we see an example of an IFR pullback, where we end up with an IFR instantaneous of 1.06, so below 1. So at that point we have a drift. We have lost the equalization. If it happens, my recommendation is to measure again, because there are some correction possible that we are going to explain, but sometimes the drift is due to some other factor that it is worth to understand and to acquire under proper conditions. So let's see how we can correct it. If it is a small drift, probably we can correct it without major dramas. See this example? We end up at the pullback with a slight drift of 3 millimeters of mercury. If we do 74 minus 71, we have a drift of 3 millimeters of mercury. So we can calculate manually our FFR. The automatic measured FFR is 0.51 by the system, but we can manually calculate dividing 61 minus the drift divided by 118. So we end up with a drift corrected FFR of 0.49. Sometimes here it plays no role because it's significant anyway, but sometimes it can play a role. Problems with hyperemia. This is sometimes not very well known. The most common problem with the hyperemia is an incompetent venous access. You have problems with your venous access, and the adenosine is not arriving to its target. But another reason, which is also very common, and it's not so well known, is that the antagonists of adenosine are the methylxanthines. The methylxanthines and the dipyridamole test, you give at the end theophylline as antidote of the dipyridamole or of the adenosine. And the methylxanthines are in the coffee, in the tea, and in the chocolate. We have the caffeine, the theophylline, and the theobromine. These three components are going to neutralize the effect of the adenosine. And it's seen very commonly. We give adenosine full dose, we see that the patient has absolutely no effect, and then we ask the patient to confess. Did you drink coffee today before coming here? Yes, but only a small cup and 1 hour ago. Okay, that's the reason. So he should come back to measure the FFR under proper conditions. Okay, another important detail is the wedging. It happens also very commonly in proximal or ostial lesions. And it's that your guiding catheters sometimes inadvertently goes too deep and occludes the coronary vessel. So if we normalize, equalize, or measure under these conditions, we are losing the proper measurement of the aortic pressure. This is what happens with the catheter, with the occluded catheter. So we see no differences because, of course, the catheter is occluding, and both the PA and the PD are measuring the same distal pressure. But if we notice that and we remove the catheter, then we have the proper gradient, the proper pressure gradient. We can sometimes, when this happens, if wedging happens, we will see that the curve is ventricularized. But we will not notice that if we have a catheter, a guiding catheter with side holes. Then we will not notice that wedging is occurring. That's why we strongly recommend to measure FFR without side holes. And finally, the wiping. The wiping is due to damage of the wire. If we have a knuckle wire, the sensor bumps against the vessel wall and the measurement of the distal part becomes unstable. So it's an inaccurate registering. Another common phenomenon is the so-called reverse gradient, and it is now very common because we start to measure FFR in vessels without stenosis because we want to assess the microvascular function distally. So we have no pressure drop, we are equalized, and when we go distal with the wire, all of a sudden the PD becomes higher and you have a PDPA or an FFR above 1. So, and my fellows say, that's impossible, we lost the equalization. And they go back and they are equalized. And they go distally, and then the PDPA is above 1. How is that possible? That happens typically in the circumflex or in the right coronary artery, because we normalize or equalize at the level of the ostium, but our wire goes slightly lower. So the hydrostatic pressure that the PD is measuring can be higher than the pressure that was measuring at the ostium. And that's the reason why we have the PDPA above 1. And another important mistake is that we take the FFR value that our machine, our system is telling us. And very frequently this is wrong, because the machine is going to register automatically the lowest PDPA value of the register. And sometimes it's not the right FFR, because these are the curves before the adenosine has come. When the adenosine comes to the receptors at the heart, the curves start to descend. But most of the times they do not do it in parallel at the same time. If the yellow curve, which is the distal curve, descends faster than the aortic curve, then we have an artificial gradient for a few seconds. But then the curves start to go parallel again under maximal hyperemia. And the FFR is the lowest value at this part of the curve, at the steady state phase. So you have to disregard the value that the system is giving you automatically, 0.51, and take manually the lowest value at the steady state phase. So this is something which is very commonly, a mistake that is very commonly done. And it's something I like very much. If we have tandem lesions, see this coronary artery, we detected 2 potential targets there, and then so we measure the FFR. Distally we have 0.78, so we have to do something. And between the lesions we have 0.83. I have one fellow which systematically takes the wrong decision, but now you will take the right one. Which lesion we have to treat? Distal or proximal? Who goes for the distal lesion? Who goes for the proximal lesion? Okay. Okay. So, I mean, my fellow is in the structural part, so it's not so bad. So she thinks, okay, 83. So the proximal one is not significant because distal to the lesion we have 83. So the important one is this one, because distal to the second one we have 78. However, if we start by an FFR value of 1, the proximal lesion represents a 17 points fall in the FFR value. And the distal lesion represents only a 5 points fall. So this step is what is more significant. You can elegantly calculate that using freely available software or calculator, which is free online, and you can manually enter the PDPA values distal and between the lesions, and you will obtain the predicted FFR. So the FFR that you will have due to the lesion if you treat the other one. In this case, you can see that no lesion is per se significant, left alone. But the most significant one is the proximal one. So the ones who selected the proximal one, they were right. Okay? So, in conclusion, FFR is easy and accurate, but it is very sensitive to subtle methodological details. So we have to equalize a measure with flat saline in the system, with a closed valve, with the introducer removed. Check always the drift. Make a pullback and verify that we remain equalized at the end. Please, no side holes in the guiding catheter. Attention to the wedging, whether your catheter has gone too deep and we are measuring something wrong. Take manually the FFR value at the steady state, because the systems are going to mislead you if you don't take this into account. And correct the value in tandem lesions. Thank you very much for your attention.
Thank you, Juan. That was, I think, really useful and practical presentations. So, questions, comments? I think that...
I just may have one. Probably 7, 8 years I was testing a fiber optic FFR wire. You probably know that. Even at that time, I tried to build a trial where we were using this wire in bifurcation stenting. So in the main vessel first to test the lesion in the main vessel. After that, pull back to go to the diagonal and fix the situation for the diagonal branch. And they said that they had no drift. Is it true, or this is,
Well, I have less experience. I have tested them, and they are significantly more expensive than the piezoelectric wires, but that they have several advantages. An important feature is that the piezoelectric wires are sensitive to blood. And for instance, if you disconnect, for instance, to measure the FFR post-PCI, if you disconnect that, it's very easy that you get blood into the sensors. And then this interferes a lot. This does not happen with the optical wires. And I cannot verify whether it is true that they have zero drift, but in my experience, they were far more stable than our piezoelectric wires, and I never had a drift. However, my experience with them is still limited.
I just have a comment. It's interesting that when we first started doing physiological studies, we took absolute values. We put the pressure wire distally and we measured the pressures. As we have evolved, we are doing more and more pullback, and now most lesions we would do a pullback. It's unheard of that we just take absolute values. And I don't know if it's because the software is so much better or that our understanding of the physiological characteristic of lesions have advanced. So we depend a lot on pullback. That right? Isn't that? It's mostly a comment, not a question, and it's also an interesting observation I've made.
Yes, the pullback at the end is obligatory part of the FFR measurement. Just not only the absolute value, just right. As a conclusion probably, as a message for the fellows.
I think maybe Professor Heinrich would confirm that, but FFR was initially designed for a focal lesion.
Correct.
To assess a focal lesion. But also the drug-eluting stents were also designed to treat simple lesions. But once we have established the method, we start to extend the treatment or the assessment to more complex cases. So we have to be flexible with.
Thank you, Juan. The next speaker will be Ravi Nair, and his topic is specific lesion assessment, serial lesions, left main diffuse disease.
This is the pointer. Okay. I'd like to begin by thanking the organizers for inviting me here. I think this is my 3rd or 4th visit. And of course I have to thank Denitsa for organizing my trip far from home. It's always been wonderful to come here. And all the people that I have met, thank you for your hospitality. So I'm coming from Cleveland, and those are some nice pictures of Cleveland. And how does this pointer work? Does this pointer actually work? Or? Oh, I didn't want to change that. Or, okay. Well, the weather in Cleveland is more or less what we have here. No different, but that's the laser, okay. And do I point it there? Yeah. And of course, when the weather is nice, it looks very beautiful, but it's not always like that. It can be dark and gray, just like it is now for a few days in Sofia. So on the basis of all the introductory lectures that we've had so far, I'm going to base my talk on how do you assess specific lesions. And I'll focus on the evaluation of serial lesions, how to evaluate left main lesions, and diffuse disease. Obviously, we are not talking about lesions that on angiograms are very clearly severe, and no matter how we measure the degree of stenosis, if we call it 70 or 80%, rarely do we need any physiological assessment. So we are looking at lesions that angiographically are more moderate, less than perhaps 50%, where we are not sure what the revascularization strategy should be, if any at all. We've seen this graph before, so that we have evolved from hyperemic physiological measurements with fractional flow reserve. We have moved into the era of 9 non-hyperemic pressure measurements and pressure ratios. And the various non-hyperemic pressure ratios are IFR, DPR, DFR, etc. And though the validation has not occurred to the extent that FFR has been validated, because it's been around for a long time, it looks like we are evolving to an area where most of these pressure indices are equivalent in terms of their ability to predict the physiological significance of lesions. Obviously, with FFR, we have to have a patient that tolerates the intravenous adenosine. The expense, of course, that adenosine will cost, and of course the time it takes, though it's short, for the adenosine to be started intravenously and to achieve a steady state. So what has happened now is that in the interest of time and ease of use, we are evolving to the non-hyperemic pressure indices. My presentation will focus on these specific areas and how we can use these non-hyperemic and hyperemic indices and how it correlates to our management strategy in terms of revascularization or not. Now, we are moving beyond invasive physiological pressure management, in the sense that you heard earlier that we can now do CT-FFR, completely non-invasive way of measuring the fractional flow reserve in patients that have coronary artery disease. Obviously, there are some caveats that has been mentioned, the hemodynamic stability or instability of a given patient, overlap, etc. We also have in-lab angiographic related FFR measurements by cath flow, for example. And this is obviously a very easy technique because you don't have to put any wires down in any vessel. You don't have to give intravenous or intracoronary adenosine. You have to have relatively good pictures, of course, coronary angiograms without any overlap. And with the algorithm that the particular manufacturer has created, one is able to measure FFR quite accurately, and this has been validated by comparing it with invasive FFR. So we are evolving into the direction where maybe wires will not have to be used in many cases. In some situations, you do have to use invasive techniques. When we've seen this slide before, so when you compare FFR or the hyperemic response and the non-hyperemic indices, it has been seen in various studies that there is significant degree of concordance, so that these indices do seem to compare with each other quite well, and decision made on the basis of either IFR or FFR in these trials where both these indices were gathered, the outcome in terms of revascularization strategy or not, the significant adverse events in both arms were about equal. So we can definitely say with a great degree of confidence that FFR and the non-hyperemic indices can be used interchangeably. We will come to this Bernoulli equation and Purcell formula later. This has been discussed at some length before, but suffice to say is that when you have a diffuse lesion, the friction coefficient is more important in determining flow, whereas when you have a focal lesion, the separation coefficient is more important to pressure measurements, and so that one can decide basis on the results of FFR or IFR whether it's a diffuse lesion or a focal lesion. I will talk about it a little bit later. What are the issues with left main disease? The significance of moderate disease in a left main is sometimes very hard to quantify. Why is that? Because the left main is very short in length. There is very often on angiogram overlap of vessels. You can have trifurcation of the left main especially, and you cannot quite see the left main stenosis. There is very often what's called reverse tapering, so that the ostium naturally is narrower than the body or the distal vessel. There is no disease. It's just the nature of the left main that there is reverse tapering of the vessel. So that if you were to evaluate fractional flow reserve of the left main, the cutoff value is 0.8, below which it is usually recommended that you do revascularization either with stenting or bypass surgery. If you do have, it is very rare that left main is not in association with disease elsewhere in the left circumflex and its branches, or the left anterior descending and its branches. So it's very rare to see isolated disease, and it's always a question as to what impact the downstream disease, how does that relate to the degree of left main disease. And so it is usually recommended that the FFR be obtained in the disease-free vessel. And these are some of the examples of left main disease. So you can have isolated left main disease, and you can put the wire down either into the anterior descending or the circumflex, and a pressure gradient can be measured, and depending on that, treatment can be offered. Because of the size of the LAD and the amount of myocardium that it serves, usually the wire in the circumflex is more reliable. However, if the wire in the LAD shows that the FFR is abnormal, then of course the disease is physiologically significant. If you have disease in the LAD, doing a pullback of the lesion in the LAD across the left main is advisable, and this is akin to any tandem lesions anywhere. Also, if you put the wire down the circumflex, you are likely to have a more reliable result. And the same is true if the disease is in the circumflex. If you have ostial disease of the anterior descending or the circumflex, that along with the left main, that would be considered a single lesion, and therefore if it is abnormal, you will put a single stent that goes into the left main. The recommendation, however, for left main disease is that the choice always is intravascular imaging. And so that if the area is more than 6 millimeters square, the revascularization is deferred. If it is less than 4.5 millimeters square, depending on the size of the patient and the degree of plaque that is visualized either on OCT or IVUS, one can decide whether this plaque and this stenosis in the left main is significant or not. And if there is any question as to where we are, then physiological assessment can be done. And how you make that decision is seen here. FFR more than 0.8 means you defer, IFR 0.89 and defer, less than 0.8 and 0.89 you would revascularize. These tandem lesion was already discussed. Tandem lesions are defined as two discrete lesions that are separated by some authors by 20 millimeters. There are other ways you can define. So and how you decide on tandem lesions was already discussed, but I'll go over it. The FFR measured distally if abnormal does not identify which is the culprit, and this was already talked about. FFR in between the lesions is also unreliable. And then if you do an IFR pullback, there will be two-step drop in pressure, and one can decide on which lesion to treat first depending on where the delta is the greatest. And it usually is advisable that once one lesion is treated, you measure FFR or IFR again of the residual lesion and then decide on treatment. And this is what happened with tandem lesions. This is again a repetition of what was said before, so that if you have two tandem lesions, you can measure an FFR of 0.76, but once the proximal lesion is treated, the distal vessel is found not to be physiologically significant. So you need to do a pullback, decide where the maximum gradient is, treat that vessel, and re-evaluate the residual lesion to decide on whether to treat both lesions. So this is what happens with serial lesions. This was mentioned again. You have significant drop, two-step drop that shows you what the pressure gradient is across each lesion. You treat where the pressure gradient was the greatest, show the greatest drop, reevaluate, and then treat the vessel, the other lesion, if it is still present. This would be a definition of a diffuse disease somewhat. 20 millimeters or longer would mean diffuse disease. If you put a wire across this, and if there is a significant physiological significance of this particular lesion, one would decide you want to treat it. Now, not all diffuse disease vessels look like this. You could have diffuse disease that is 40 and 50 millimeters long, and then, of course, the decision of treating or not treating is very different, which I will come across. And the top screen A will show you why FFR and IFR will vary because of the Bernoulli and Poiseuille's equations that talk about the energy loss based on either friction or separation. So if you have a more diffuse disease, then you have a slow decrement in pressure. If you have more focal, then you have a stepwise reduction in pressure across the lesion. Now, one important thing to take the subjectivity out of it, because if you just look at the curve, what we are looking at are ideal curves. When the curves are not that definite, then you may want to use the pressure pullback gradient as a measure of how significant it is, how focal the disease is, or how diffuse the lesion is. And if you quantify the pressure gradient PPG from 0 to 1, closer to 1 means it is more focal, further away from 1 it's more diffuse. And this is the pressure pullback gradient calculation. Is much too complex for me to discuss, but if people that are interested can go back and look at it. So this is how I would summarize how you would do the pullback and what would happen if you had diffuse lesions focal lesions and mixed lesions. And this particular slide will then show you what the treatment strategy would be depending on what kind of lesion morphology we are dealing with. So in the top panel, if you have a focal lesion, it is very simple that you would stent this lesion. The second panel shows diffuse disease. One would want to defer treatment here because you would be otherwise over-stenting diffuse stenosis. You would not know from where to start and where to end, and whether the patient would actually have any decrease in ischemic symptoms if you have such diffuse disease. However, if in the diffuse disease this would be the mixed variety, if you had a step up, you could possibly just stent there and not stent the entire vessel. If you had purely diffuse disease, you may want to defer any kind of revascularization strategy and just treat the patient conservatively with medicines. Or if there is a healthy vessel beyond what you think is a diffuse disease, you could consider bypass surgery and not stenting a very long segment, which would not be the ideal solution for a given patient. So this would be the algorithm, a little complex slide, but this was the algorithm as to how you would approach a patient in whom you suspect ischemia, but it's on the basis of non-angiographically relevant stenosis. You would do FFR or non-hyperemic, and then depending on the various values, you would treat or not treat, stent or not stent, surgery or not surgery for various lesions. And to conclude on time, this is my summary and conclusion. That is, physiological evaluations in certain unique situations need a sound knowledge of the principles. So you need to know the principle as to how you lose energy in focal versus diffuse lesions. Hyperemic and non-hyperemic pressure ratios, as I said before, can be interchangeably used in most situations since the concordance is pretty good. And the outcome based on which method you use is still very, very similar. So the concordance, even in terms of treatment, is very good. Pullback measurements, as I mentioned later, has added another layer of diagnostic accuracy. And with the software that is available, you can measure various indices which help you even further in making your decisions. FFR is very reliable in discrete lesions, whereas non-hyperemic measurements diagnose significant diffuse disease. And this is very important when you have borderline cases where where you fall in the gray zone. So in certain situations where there is equipoise, which means you're very much in the gray zone, the addition of imaging modalities is very, very useful in making your final decision.
That was amazing. First because the presentation, and the second because you were just in time. Mm-hmm. And do you have some tips about measuring FFR on the left main and distal left main disease, let's say? Because the osteo left main usually it's not so disputable. I mean, when there is a wedging of the guiding catheter, so we know that it is compatible with the incise with the guide catheters. 90% significant, but with distal lesions there are some cases with it's about 50%. You do FFR, you do IVUS, and there is it was well mentioned, I think, that practically in those cases we have to use both FFR and IVUS.
Yeah, Dobin, you answered your own question. So, I think it is best to use the recommendation that you would IVUS the left main, and when in doubt, because the reason is if you do suspect left main disease, it is a very rare operator that will do left main stenting without using IVUS. So you will see the degree of calcification, then of course you can check the results later. So this way you can just use the one modality instead of using an FFR. And if it's abnormal, then using IVUS to stent the vessel. But if you were going to use IFR or FFR, obviously you cannot be deep-throating the guide. You have to have adequate flow. And then you have to decide which vessel you want to put your wire in. So if you have downstream disease, it's going to have significant impact on what the physiological data is going to be in the left main. So put the wire down the non-diseased vessel. If you have very proximal circumflex, ostial circumflex, LAD lesion, it's one lesion. You just have to stent from left main into. So these are just practical hints as to how you would tackle left main. So to summarize, I would do IVUS, and if the area is adequate, then leave it alone. However, it's that gray zone of 5.5, 5, what do you do? So then you have to see how much plaque is really there. So you might have a smaller individual, a smaller lady whose area is 4.8, but there isn't much plaque. So you say that is adequate. I don't think you at that stage you will need FFR.
See,
So,
Juan, what is your approach in those situations with the distal left mains and IVUS FFR with the borderline cases?
I think for the decision to treat or not to treat, I always try to stick to FFR or to a physiology value. And if it is possible, I like to measure in both vessels, because
correct.
most cases you will obtain different values.
Correct.
Because you have the same pressure drop theoretically, but the pressure drop also depends on the subtended myocardium, which is usually much larger in the LAD. So if you are measuring at in the LAD, usually your FFR is lower than if you are measuring in the circumflex due to this small value. And I take the worst possible scenario for the decision. But it is also true that now we should not do any PCI in the left main without imaging, without IVUS, in most of cases. So I am luckily working in a hospital without budgetary restrictions, so I can liberally use both of them. There is a creative solution. It's the so-called UFR, which is ultrasound flow reserve, which is a computational physiology based on IVUS, on high definition IVUS. And it uses to work very fine. And if you only have one tool, maybe you can use that and have a reliable approach. But the point of using an MLA cutoff, it is becoming kind of suboptimal nowadays when we have so refined physiology. Still it works. It does not work in an ordinary vessel. It still works in the left main because you have a predictable
It's only
amount
the left
of
main.
subtended myocardium. So it makes sense to have a cutoff value. But still, if it is possible, I don't have time restrictions or so on, I try to take the decision based on physiology.
May I go briefly on something you have not discussed? I won't discuss, of course, because you know FFR I don't understand. When you have the patient has another vessel which is occluded, we know that the measurement in a patent vessel with any lesion is giving more severe stenosis than it is really. So the question is, do you have to open the right when you have mid-LAD lesion with FFR less than 0.70, or do you have to treat the LAD and leave the right occluded? That's, you have not discussed this question, so I think it's interesting.
Okay. I was going to give a brief tip. If your intention is opening the RCA, then the most reliable, the occluded vessel, the most reliable index is the computational physiology, QFR. That's the one you have to follow. However, if your intention is leaving the patient with the occluded RCA, then your FFR is the right value. Because, because the LED will have to provide to provide the flow for the occluded vessel. So the FFR is the one who is making the decision.
Yeah, but this is purely a physiologist answer. The question is, do we have to open this CTO? Which means, if you open the CTO, then you can calculate a true FFR on the stenosis vessel, no?
Yeah.
Valerie?
Oh, I'm sorry to...
Fellow course.
And we are a little bit going away from the guidelines.
I'm sorry.
It's very interesting. It's just a joke, but no. It's just a joke, but really, we have to make a clear message to these people. And if we have to go for example, in this case, with the right and the LED, in my view, we have to estimate whether we have a vitality and we have indication for revitalization until how we can obtain complete revitalization of the situation. And probably start with the right, because the CTO is not a granted success.
Okay, just we'll go further. Obviously, this is my better version from the scientific point, and Dr. Mileva will give my talk about the microvascular disease. Moreover, that she has some personal achievements in this area, and I think that she is one of the best persons for these presentations.
Also very strange. For me, this is very strange. Please.
Yeah.
Thank you very much for the opportunity to speak in front of all of you today. Yes, the talk today would be about everything that remains hidden, let's say so, and the assessment of non-occlusive coronary artery disease. Usually what we see every day in our clinical practice, either in coronary angiography or in coronary CT angiography, we see the epicardial coronary arteries, which actually are around 10% of the whole coronary circulation. What remains hidden by the conventional imaging techniques is the coronary microvascular, which is actually 90 or even more of the whole coronary circulation, 90% or more of the whole coronary circulation. Usually, we focus on the epicardial coronary arteries, which are actually the arteries that are above 400 micrometers. Then we have the prearterioles, the arterioles, and the capillaries, which are all microvessels below 400 micrometers. If the epicardial arteries are the ones that are most important for the transport of the blood flow, then we have the microvasculature, which is also very important because this part of the coronary circulation is actually responsible for the regulation of the blood flow and for all the metabolic exchange that is important for the myocardial functioning. If we focus on the pathogenesis and the damage of the microcirculation, it is rather complex pathogenesis. From one side, we have the structural mechanisms of impairment of the coronary circulation. We can have increased medial wall thickness. We can have intravascular plugging, perivascular fibrosis, or capillary rarefaction. But apart from the structural mechanisms, we also have functional mechanisms such as the microvascular spasm that can be endothelial dependent or endothelial independent. So this is a rather complex combination of both structural and functional mechanisms that all lead to microvascular dysfunction. Whatever the complex pathogenesis, the final pathway is the same. The impairment in the optimization of the coronary blood flow at a response of stress or increased demands leads to impaired myocardial perfusion, which, as we all know, leads to myocardial ischemia. It is important to always keep in mind that there is a very high overlap between structural epicardial coronary artery disease and coronary microvascular disease. It's not one or the other. Very often it's both type of disease. So we should always keep in mind that there is a high overlap. And when we speak of coronary microvascular dysfunction, there are a lot of methods for functional diagnosis. We have both the non-invasive methods and the invasive methods. And it's important that as we have so many techniques to assess the microvascular function, we also have very different thresholds and very different results depending on the method that we use. If we look in all previously published studies assessing patients with non-obstructive coronary artery disease and with ischemia, we see that actually there is a very high heterogeneity in the findings of the prevalence of coronary microvascular dysfunction based on the method that was used, either non-invasive or invasive methods. We see the high variation of the prevalence of CMD among all these patients. These are 57 studies. In the end, the pooled prevalence of CMD in all these patients with ANOCA was 42%. We see that almost 1.5 times females are more likely to be positive for CMD. And again, we see a very high prevalence of vasospastic angina in all these patients with ANOCA. So what we see until now, we have a very high prevalence of coronary microvascular dysfunction in these patients with ANOCA, despite the different methods that was used. If we focus on the invasive methods, because of course this is a very invasive congress, we have different methods both for the epicardial disease and for the microvascular coronary structures. So if we focus on the epicardial coronary arteries, it was talked a lot until now about the fractional flow reserve, so I will not focus on this. But if we focus on the microvascular part of the coronary tree, we can use the coronary flow reserve and the index of microvascular resistance. I would not talk anymore about the FFR because we learned a lot until now about it. But if we focus on the coronary flow reserve, this is the gold standard, the Doppler method for the assessment of coronary flow reserve. We assess the coronary flow velocity using Doppler wire, both at rest and at hyperemic conditions, usually achieved by intracoronary or intravenous adenosine or intracoronary papaverine. So we have the coronary flow velocity at rest, at baseline, then we have it at maximal hyperemia, and the ratio between the two gives us the rate at which the flow increases, so the reserve of the myocardium that we have to increase the flow. CFR above 2 is accepted now as the current reference for normal coronary flow reserve. Apart from the Doppler method, we have the thermal dilution method. The thermal dilution method uses bolus injections of cold saline. We use the mean transit time of the cold saline from the ostium of the artery until the thermosensor, and the time that is required for the cold saline to transit from the ostium to the sensor is a surrogate of the flow. So again, we measure this time at rest and at hyperemia, and the ratio between the two is the CFR achieved with thermal dilution. Again, above 2 is accepted as normal. Using thermal dilution, we can also evaluate the index of microcirculatory reserve, IMR. The specific thing about the IMR is that it is taking into account also the distal coronary pressure, the PD, and in these terms, it is accepted as a very much more specific method for microcirculation, not for the coronary artery as is the CFR, but only for the microcirculation. IMR, index of microvascular resistance, below 25 is now accepted as a marker of microvascular disease. This was bolus thermal dilution. As I said, we are injecting boluses of cold saline. Anyway, there is a method also adapting thermal dilution, but continuous infusion of saline, cold saline. This is called the continuous thermal dilution. The continuous thermal dilution method gives very important advantages that you can actually quantify the absolute coronary flow by the continuous thermal dilution. And assessing the absolutely coronary flow, we can actually have this novel method that is called the microvascular resistance reserve, the MRR, which is the newest method for microvascular function assessment, and it is until now proven that it is more specific for a microcirculation because it is actually assessing the absolute flow at hyperemia and the absolute flow at rest. The study that was published in JACC Imaging last year showed that it is relatively operator independent and it is specific for the microvasculature. Okay, so until now I showed you a lot of methods that you can assess microcirculation. I showed that a lot of people can have coronary microvascular disease, but in the end, what is the point to have all these methods, to spend more time in the cath lab, to spend more resources in the cath lab? Well, let's imagine what is the usual typical patient that we have, maybe middle-aged female patient. She comes to the cath lab with some symptoms of chest pain, but in the cath lab you see on the normal coronary angiography no epicardial stenosis. Then we usually say, okay, maybe you have reflux, maybe you have some gastric problems, maybe you have some lung problems, maybe it's all anxiety, it's all in your head, so don't worry. But we actually skipped the part of the microvascular assessment, so maybe this patient actually had some heart problems, but we didn't evaluate it. And if we look back at some studies about angina and normal coronary arteries, we see that in a study with more than 11,000 patients with stable coronary artery disease compared with patients with no coronary artery disease and asymptomatic, we see that asymptomatic patients had much better survival than the ones that had some symptoms, even though they had normal coronary arteries. So this is very important. The angina is saying something. It's not just there, the symptoms are there for something, and these patients have worse clinical outcomes. If we see the WISE registry, this is a registry of only women, again with non-obstructive coronary arteries or with absolutely normal coronary arteries, but with angina, and we see that even the arteries were absolutely normal, but they had some angina, they had 3 times more MACE in terms of myocardial infarction, stroke, or heart failure hospitalization at a 5-year follow-up. And then I would like to show you 2 studies that were published in the last year. Similar design, the one focused on the patients that first had positive bicycle stress test, and then they were referred to the cath lab. And in the cath lab, they underwent not only coronary angiography, but full physiological assessment. And after the full physiological assessment, it was shown that, okay, 30–40% had the emitter stenosis over 50%, so they were clearly positive stress test. However, 25% actually had microvascular disease with IMR over 25, and 40% had non-obstructive coronary artery disease with obstructive coronary artery disease with FFR below 0.8. So using the physiology actually helped the physicians to reduce the false positive stress test. It was not false positive, it was positive for microvascular disease. Another study that was just published in JACC Imaging, similar but a little bit more comprehensive, because here the patients first underwent coronary angiography with full physiological assessment. After the full physiological assessment, the patients were referred for exercise ECG stress test, and they were divided on ischemic and non-ischemic group. And then, this is the full physiological assessment. You see that the patients underwent evaluation of FFR, also CFR was measured, and what is more, also acetylcholine was injected for a test of vasospastic angina, so full physiological assessment. And we see that if we look at the ischemic and the non-ischemic group, actually the ischemic group had significantly lower CFR, but not significant difference in FFR. So the full physiological assessment actually helped the ECG stress test to receive specificity of 100. So the false positive test rate was completely reduced with assessment of microvascular disease. If before we were thinking that there is around 40% of false positive rates of ECG stress test because there was no epicardial disease. Now we know that most of these patients actually may not have epicardial disease but have some other problems in their coronary vasculature. Okay, and then what will be changed in the diagnosis if we have this diagnosis? What are we going to do? Well, I think most of us you have heard about the Cormica trial that was published in 2018. These were all patients with non-obstructive coronary artery disease measured both by QCA and FFR. And then the patients were stratified in two groups, one that had standards of care, but other group that received stratified therapy based on the physiological assessment. So the patients were divided on those with vasospastic angina, those with microvascular angina, and those with non-cardiac problems. Those with vasospastic angina were treated with calcium channel blockers and lifestyle modifications. Those with microvascular angina were treated with beta blockers and lifestyle modifications. And those with non-cardiac problems were just stopped to anti-anginal treatments and were referred for search of another problem. And we see that at a follow-up at 6 months, the Seattle Angina Questionnaire results show that actually the patients that received stratified treatment according to the full physiological assessment results much better both in terms of physical limitation and angina frequency. So the symptoms of these patients were significantly better even at the 6 months after the stratified therapy. So treatment matters in these patients. Based on these results, in 2021, the European Association of Percutaneous Coronary Interventions published the consensus documents where everything that we spoke until now was actually recommended. Patients should undergo comprehensive evaluation with comprehensive history and physical examination, then comprehensive non-invasive evaluation with stress test, with transthoracic Doppler echocardiography and other non-invasive stress tests. Then the patient should undergo invasive functional evaluation, both with FFR, CFR, if possible, IMR, and the patient should be stratified according to these findings, either epicardial disease or vasospastic angina, either microvascular angina or microvascular vasospastic angina. Of course, if we exclude all these problems, then yes, we can say you don't have any cardiac problems, you can go and look for another reason. And the treatment is different based on the different inokindotypes. If there is a microvascular angina, then yes, we should prescribe beta blockers, calcium channel blockers, and all the treatments recommended also for the epicardial coronary artery disease. However, if there is a vasospastic angina, beta blockers should not be prescribed. We should use calcium channel blockers, long-acting nitrate, if possible, nicorandil. And I would like to show you a case from our clinical practice, 64-year-old male that had essential hypertension, dyslipidemia, smoking, typical stable angina, on moderate physical exertion from the last couple of months. Nothing specific from the clinical exam. We found dyslipidemia in the laboratory findings, and he was completely stable. Echocardiography was not remarkable for any findings. We also performed echo stress test with hand grip. This is something that we are doing in our clinic, and we saw that the global longitudinal strain was completely normal at rest with minus 22%. However, after the stress, there was no problem in the myocardial deformation, but also there was no increase. Usually, we should expect to have some increase in the global longitudinal strain. Here, it was exactly the same. The patient was referred for invasive coronary angiography and functional assessment. We see with the right coronary artery, I think no epicardial coronary stenosis. Then we see the left coronary artery, again with no significant epicardial stenosis. Then CFR with the Doppler method was calculated in our clinic. We are using the protocol with intracoronary adenosine. First, 50 microgram of intracoronary adenosine was used, and you see that the CFR was 1.8. so below the cutoff value of 2 that we said was the normal reference. The adenosine injection, the dose was upgraded, and you see that again the CFR is 1.7. We even go up to 150 micrograms of adenosine, and again the CFR was 1.4. So there was a reduced coronary flow reserve in this patient. What is more, we are also doing the angiography, TIMI frame count again with rest and with adenosine. We see that the TIMI frame count increases a little bit, the flow becomes faster, but not significantly different at rest and after hyperemic agent. We discharge this patient on the therapy of beta blocker, calcium channel blocker, trimetazidine, and therapy for dyslipidemia, and we hope he will feel better for now. And just the last aspect of the presentation, as the topic is the non-occlusive coronary artery disease. Usually when we're speaking of occlusive or obstructive, we usually think of plaque, of atherosclerotic plaque. But there is some very important aspect that I think we usually forget, and it's the so-called myocardial bridging, or as I found, this is something very interesting for me. This is the first, at least the first that I found, pathohistological report of the Murrow coronary in 1950. In these 120 materials of autopsies, they found that 1 of every 5 of LAD arteries had intramyocardial course. So something that sounds very common, 1 of every 5. However, there are a lot of studies and geographic studies that report lower prevalence of myocardial bridging. 1 is even going to 1% of myocardial bridging. If we look at the studies comparing CT and invasive coronary angiography, we see very high discrepancies. Some studies report this study. They evaluated the same patients both with CT and angiography. Investigators were blinded, and we see that 50–80% of the patients had the myocardial bridges seen on CT, but when they were evaluated by coronary angiography, the percentage of myocardial bridges was only 13. And this is an article that was just published in the Journal of American Heart Association, evaluating patients with myocardial bridges. The patients underwent functional evaluation. For me, something very interesting, that the patients even underwent stress test on the cath lab. They were in supine position doing ECG stress test, and we see that actually the patients with myocardial bridges, when compared with the normal patients, had significantly lower FFR and significantly lower CFR compared with the completely normal patients. What is more, there was perfusion deficit in the patients with myocardial bridges compared to completely normal patients. In the last year, in our center, we did a total of a little bit of more than 800 patients with coronary CT, and 38% of them had any evidence of myocardial bridging, something that for me is very high, and something that we discussed with Professor Vasiliev, that maybe should not be considered as an anomaly, but as something as a normal variant if such a high percentage of people had myocardial bridges. I'm really finishing with this case. It's just a female 57-year-old, no significant medical history until now, no concomitant medications. However, from the last month, she started feeling these symptoms of precordial oppression, and it was something typical for us, that it became more frequent with the cold weather outside. On physical examination, nothing remarkable. Also in the laboratory, everything looked normal. Echocardiography looked normal. We performed the coronary CT, and we see on the LAD this intramyocardial course of the LAD. What is more, we measure all these myocardial bridges. We see that the length of the intramyocardial course is 31 millimeters, and there is 4 millimeter depth under the myocardium. You see here on the cross section how deep is the artery inside the myocardium. So this patient was referred for a cath lab to measure this myocardial bridge and the stenosis that is causing. You can appreciate. For me, it's very interesting comparing the CT with the invasive coronary angiography, because on the CT you saw how long was the intramyocardial course. On the angio, You see how short is the occlusion from the myocardial bridge, and for me this is this most deep segment that goes under the myocardium. FFR was measured and it was 0.72. However, for the moment we're not really sure what to do with this patient. She was discharged on long-acting calcium channel blocker, on trimetazidine and amlodipine. I think it's a mistake. And the patient was followed up in 2 weeks, and she said she felt better. I don't know if it was due to our treatment or placebo, but we were happy that she's happy. As a conclusion, I would just like to focus that we should not treat the artery. Even if we see that there is a problem or not, we should treat the patient. If the patient has some symptoms, some angina, this is usually telling us that there is some problem in the myocardium. We should focus not only on the epicardials, also in the microvasculature, also in the epicardial vasospastic angina, and also we should not forget the myocardial bridges. Thank you.
So, questions, comments? Juan?
Congratulations for the excellent review of the microvascular function and some additional physiological issues. I'd like to ask you about the variability of these indexes, CFR and above all IMR, depending on the position of the wire, because actually it's one of the difficulties to standardize the measurement, because you obtain different microvascular resistance depending where the sensor is placed. What do you think?
I completely agree, and this is something that we even discussed, that we should try to study the different position of the wires and try to evaluate the difference in measurements.
Yes, this is what actually we observed, that practically it's highly dependent, especially for LAD. And if you have something proximal lesion in the LAD, where to place exactly the sensor, just 1 centimeter below the distal edge of the lesion, as you see it, because as you see it in angio, it's not always where the end of the lesion is, or in more distal positions, and we compared quite a good number of patients for the moment, and there is a discrepancy. In all of the cases, there is the discrepancy, and personally I don't know at the moment where exactly we should make this measurement, exactly at what position, how far from the distal edge of the lesion.
I have a more practical comment and question. First is, we have a special clinic for patients like this, and you see a lot of people with atypical symptoms. A vast majority don't have what we call angina. And the dilemma is, how do we test them, because they are referred for small vessel disease. Second is, many patients undergo stress testing for various reasons. They're completely asymptomatic, but you have ECG changes. Do you think we should test those for microvascular? We think it's false positive, no symptoms, ECG changes. You know, what do you do in those situations?
To be honest,
then the final thing about myocardial bridging is, okay, if you see abnormal indices, etc., yes, you can put them on some treatment. What if the patient does not respond to treatment? Do you subject them to surgery?
So first, for the protocol assessment in our clinic, at least first we really try to have the comprehensive medical history, to try to see the relationship between the symptoms and physical exertion and the weather outside as well. We do non-invasive tests always. First, we do either the hand grip test. This is something really easy. The patient is laying on for the echo exam, just doing the hand grip test, and we see if there is any difference in the strain. We also do the bicycle stress, but not so often. And honestly, I think our approach is that first we should exclude the the most important, the most dangerous problems, so the heart problems, and then only after we can say, oh, I think, okay, probably it's anxiety or intercostal neuralgia. But first we exclude, even if everything is normal, we prefer to play safe.
Ravi, probably the answer, very limited, relays on this article from the group of Divaka Pereira, which shows that practically all patients, 100% of the patients with ECG changes during stress test, all these patients, 100%, they had a decreased coronary flow reserve. So that was, and their conclusion is that if there is a change on the ECG during the stress test, and there is no significant epicardial stenosis, that means microvascular disease. What type of microvascular disease? This is very difficult to establish exactly the type, and even more difficult is to treat, because practically we don't know what to treat. This is the truth. At least in my view, but the point here is that we are so unsuccessful in treatment of microvascular disease because we don't understand the exact mechanism.
Still, I think it's important what Nia has mentioned is telling the patient it is because of the heart.
Yes.
Because sometimes, I mean, the fellow goes out and says, good news, don't worry, it does not come from the heart. And then, so where does it come from? And then the patient starts to go to the gastroenterologist, to the psychiatrist, the family complains, you try to draw attention, the doctor already said that you have nothing, and so on, and all of a sudden you perform something and you discover what it comes from. And it is true. I mean, now the doctors, the clinical cardiologist asks, okay, so she has microvascular dysfunction, so what? What should we give her? So, well, I mean, there are plenty of reviews telling that you can give them everything. So when this happens, that means that we don't have a specific treatment. We have even a series with reducer for patients with a positive scintigraphy or so on, but it's not always the case. But I think it's important just telling the patient, good news, it comes from the heart. It has good prognosis, but it comes from the heart. So you are not mad, you are not crazy, you don't need a psychiatrist. Okay, so thank you so much, everybody. And we will have now 10-minute break, and then we will have an opening ceremony.